Welcome. Thank you so much for that kind introduction. I'm just going to share my screen. Get it ready. So as you have heard, I'm Cathy Scrimshaw. I'm a family physician. I work down in Pincher Creek, and I just want to acknowledge that I do live and work on the traditional territory of the Blackfoot Confederacy, and have had the privilege of working very closely with my colleagues on the Piikani Nation. I also want to acknowledge that Emily and her team have worked in our clinic in Pincher Creek. And so we've had that experience of that clinic to clinic mentorship, which fits into a lot of what we're going to be talking about here on Project 𝐒𝐂. So Project 𝐒𝐂, 𝐒𝐂 is an acronym that means extension for community healthcare outcomes. And I just want to do a few disclosures. So I am a paid employee of the Alberta College of Family Physicians, and I also work part-time for the Alberta Health Services in the Indigenous Wellness Corps. I'm going to do the disclosure for Ted as well, and he provides clinical services at Alberta Health Services and also works as a committee member for the Alberta College of Family Physicians and is one of our mentors in our mentorship network. Our program is supported from Health Canada with a contribution from the Substance Use and Addiction Program in the form of an educational grant. And we also get a lot of in-kind support from the Alberta College of Family Physicians. So our short snapper is really going to cover 5 things. The first thing is, why are we doing a pain 𝐒𝐂 for Alberta? And what exactly is an 𝐒𝐂 program? And how does it work? And is there evidence that it makes a difference in practice? Some early results from our pilot that started this spring, and some future plans. So I think the most compelling thing I read in why we're doing our mentorship network through the Alberta College of Family Physicians was when I read this in the Canadian Pain Task Force, which basically was a wake-up call. For most Canadians, the first point of contact within the health system for the assessment of pain is a family physician or other primary care practitioner, many of whom often lack the knowledge, skill, and judgment to treat chronic pain. And I have to admit, as a family physician, when I first read that, I was a bit taken aback. But when you think about the huge advances that have occurred in chronic pain research and management and our understanding, it really points that we need to improve our baseline knowledge and improve our capacity as primary care practitioners working in community, and take advantage of all the expertise of our interprofessional multidisciplinary team members. And so what we've done at the Mentorship Network is developed one-to-one mentorship between professions or within specialist and generalist colleagues. We've provided some virtual collaboration forums, but it was actually Dr. Findlay who was very interested in trying out the 𝐒𝐂 program as an ability to provide education in a different way using cases. So, oh, my slide's not advancing. So what is the 𝐒𝐂 model? So this started as is really a way to extend knowledge translation to rural and remote communities. And Dr. Findlay is going to be talking about the history. The idea is really to demonopolize knowledge. We don't know what we don't know. And so unless our interdisciplinary teams are talking to each other, our medical neighborhoods, so to speak, professionals are sharing their expertise, we can't provide the best care possible to our patients, especially with complex chronic pain. We want to increase the capacity of care in the community and address the needs of our communities. And so the 𝐒𝐂 philosophy is really all teach, all learn, generalists and specialists in all the professions learning from each other.
Thank you very much. So 2 years ago, I and probably most of you had never heard of Zoom, yet here we are this morning. We've all figured it out, and we found that Zoom and similar tools for virtual meetings have become an invaluable tool in extending our practices beyond our original four walls. Project 𝐒𝐂 was launched before this technology was widely available, and initially relied on a proprietary system to host multi-site meetings with security features, which was rather expensive, and that cost was reflected in 𝐒𝐂 licenses. However, now most, if not all, users have migrated to commonly available and inexpensive systems so that do the same job, and the cost of participation has come down significantly. Sharing best practices means that everyone has something valuable to contribute, and this is reflected in, as Cathy mentioned, the all teach and all learn philosophy. As a hub team member myself, this is very important to me, as I find that I am expanding my clinical knowledge base with the cases that we review, as well as having a chance to contribute my own 2 cents worth. And seeing common threads that everyone finds challenging to manage in complex patient care. Number three, speaking about an actual case that is selected and presented by a participating member makes the experience very real and pertinent to all participants. We're talking about practice suggestions that will be implemented to have a real clinical impact on an actual patient. And evaluation, of course, is built into our 𝐒𝐂 model as an effort to strive for a continuous improvement. Next slide, please. The history of 𝐒𝐂, as noted, the first 𝐒𝐂 was developed by a hepatologist at the University of New Mexico, 2003. New Mexico is a largely rural state with kind of one major center, Albuquerque, which is where the university is. And this particular hepatologist, his name is Dr. Sanjay Arora, was one of a limited number of physicians with expertise in hepatitis C management responsible for patients from far and wide across New Mexico. And he wondered if there were ways to support physicians in community practice to manage the patients closer to home, rather than having to have them come to Albuquerque to see him. So he developed the methodology for the initial project and found that the outcomes were equal to those of a specialist practice, and that was published in the New England Journal of Medicine in 2011. So the methodology has been validated and it's been adapted for multiple other conditions in multiple locations, and at the moment, there are over 3,000 𝐒𝐂 projects in over 9,000 cities in 180 countries around the world. Next slide, please. So how does it work? A call goes out to find a community of practice, clinicians with an interest in developing and sharing their skills in some area of clinical practice, in our case, chronic pain and addictions. A hub team is identified with representatives from clinical subject areas relevant, and in our case, that includes family medicine, addictions, anesthesiology, pharmacy, psychology, and then we add to the hub team as is needed for the topics at hand. The hub team members and 𝐒𝐂 administrators will usually take a short training course in the methodology, and in my case, this was a one-day online from the University of Toronto 𝐒𝐂 Superhub. We have about an hour and a half for our 𝐒𝐂. It starts with a short didactic lecture. We try and limit this to about 20 minutes with a question period, which may or may not actually be relevant to the case that's being presented. One of the community of practice members presents an actual but anonymized patient case, and time is then allotted for clarifying questions, first from the community and then from the hub team. And finally, there are opportunities for suggestions, again, first from the community and then from the hub team. As you can see from the model on the right, this leads to a continuous learning loop of knowledge. Our ACFP home team then follows with a summary of recommendations that are sent to the case presenter. And over time, we're developing a library of references that are brought to the by the hub team to the teaching portion of the meetings. As for myself, I enjoy teaching, I enjoy learning. It's not a huge time commitment to being a hub member, and I usually spend about a half an hour or so finding references and preparing for the meeting, so not a big time commitment. Next slide, please. Sessions have averaged, in terms of evaluations, we found that we have been averaging about 22 participants per session. We had our final session of the first series that was done just Wednesday this week. I think there were a bit more. The participants are rating the sessions very highly, both for both the didactic and case discussion portions. Most attendees strongly agreed that the session was welcoming, that they were able to share their thoughts and questions. And presenters also note that it's a valuable use of their time to participate and present. And next slide, please. And these are just a few of the comments that participants have shared with us. Thanks, it was a great experience, a fabulous case, and I'm going to use some of the things that I've learned right away to improve care of my patients. And next slide, please. So we've done our first series of 6 echoes that was done this spring. There is a second set scheduled to begin in September. We do the sessions twice monthly, so the 6 sessions will run twice monthly, September, October, and November. We feel like we're hitting our stride. We've learned a lot, obviously, in doing our presentations, and we're getting smoother at it. And there's lots of room for more participants to join. It's not limited to family physicians, and as noted, we're open to other members of allied health team that have an interest in teaching, and even better in learning as well as teaching. We'll continue to evaluate our own processes and outcomes, adapt and improve with time. And while the topics for this fall sessions have been selected, if you join our community of practice, you'll have a chance to help choose the topics for our anticipated future sessions. And thank you very much. I will turn it back to the CPEF team to carry on to the next presentation.